Welcome, everybody. This is Kirtane from Columbia University in New York. We have two fantastic speakers today. We're going to have a great discussion. We really thank the IMDS team for sponsoring this. This is the third webinar in our series. I have two friends and colleagues here. First, on my left, we've had Gabriele Gasparini from Humanitas Hospital, Research Hospital in Rossano, Milan, and Margaret McEntegart, who we go back. I'm not going to say how far back we go because it makes us both feel older, but from Golden Jubilee Hospital in Glasgow in Scotland. We're going to have a great case series with discussions, techniques, how CTO PCI particularly has evolved with the ReCross catheter, with some discussion as well. I think a lot of this has to do with discovery. It has to do with trying to reinvent or invent new techniques, new ways of approach, for maximizing the benefits of PCI for the patient, but minimizing the risks. And I think we'll have a great discussion. We aim to keep this within the hour or so. I encourage people to log in and chat because we can certainly answer those questions in real time as we go forward. And there'll be discussion sections after each of the talks. So with that, I'd like to get started. Any words from either Gabriele or Margaret? First, I like the background, the Keith Haring and everything in Gabriele's background is fantastic. Silence equals death. And Margaret is clearly working in the hospital and has all of her research files behind her. So thanks for joining, both of you.
Thanks, Andrew.
Well, why don't we go ahead and get started? I think our first speaker today is Margaret, and she's going to be discussing some cases and her current iteration of her CTO algorithm.
Thanks, Andrew, and thanks IMDS guys for setting up the webinar today. So I'm going to talk to you a little bit about how I see ReCross fit into my CTO algorithm. So when we do antegrade CTO PCI, this is really the ideal scenario. You cross your proximal cap with your wire, it traverses the occlusive segment and traverses the distal cap, all within the lumen or intraplaque using the new terminology from CTO ARC. But as the lesion complexity increases, there's less certainty sometimes about where your wire actually is within the occlusion, whether it stayed intraplaque or whether it's sections within it has exited into the extraplaque or the subintimal space. And when this occurs, this uncertainty or certainty that you've gone extraplaque within the occlusion, there's kind of two mindsets about what you do in this situation. There's the idea of parallel wiring, where either you leave your first wire in place, take a single lumen microcatheter with a second wire alongside it and try and find the correct course, or alternatively, use a dual lumen microcatheter on the first wire with a second wire again to try and parallel wire and find the correct course through the occlusion. And more contemporary, and I think Gabriele will talk about this a little bit more, using the ReCross in that situation. The other way of approaching this is to use wire redirection. So this is when you use your original wire and microcatheter and just try and redirect yourself back onto the correct course if you feel that you've taken the wrong turn. In reality, when you cross an occlusion, even if you cross the proximal cap and through the distal cap, you're never absolutely certain about what you've done until you've crossed and you've done imaging. Because sometimes we know from some data that's been published that even if you think you're intraplaque the whole way, sometimes you're not. And sometimes when you think you've been extraplaque, sometimes you're not. The other thing that's important to remember is there's not infrequently the situation where you can't cross the proximal cap. And in that situation, sometimes what you have to do is go around the cap, either by getting into the subintimal space or getting extra plaque in front of or at the proximal cap. If the occlusion is not particularly long, and if there's no significant ambiguity or tortuosity in the course, sometimes you have the situation where you go extra plaque with your wire, your straight wire, not a knuckled wire, and you've tracked past the distal cap, just past the distal cap within the subintimal space. So you haven't created a knuckle space. And in this situation, I think this is a really nice place for the ReCross catheter where you can do device-based re-entry. So you've got a relatively straight wire in the subintimal space or extraplaque just past the cap, use a device on that wire, then to re-enter just beyond the distal cap. And I'll show you a case later on that illustrates that. This can also be done using a single lumen microcatheter or a dual lumen microcatheter to try and re-enter, but it's much less predictable. And I think in my hands anyway, the success rate is much less than it is with the ReCross. Alternatively, if you end up extra plaque and you have a long, tortuous or ambiguous course of an occlusion, my feeling is the safest thing to do in that situation is to use a knuckle wire and knuckle beyond your distal cap and then perform re-entry. And again, this will be using a device and most classically using the Stingray balloon to do this. But again, I'll show you a case later to illustrate that I think this can also be done, particularly in circumstances where you can't use a Stingray with the ReCross device. Some operators in this situation sometimes will use uncontrolled wired-based re-entry, so that would be a mini star or star technique. So just a little bit about the device before we go on to look at the cases. So the ReCross is a dual lumen double hub microcatheter. So you have two separate channels within the microcatheter, and that's how it differs from the usual dual lumen microcatheter. So the white hub, the wire on the white hub will take you to the tip, but it will also allow you to exit a side port 12 millimeters back from the tip. The blue hub has a stylet that can be removed and reinserted. And if you take a wire through that hub, it will come out a side port 8 millimeters back from the tip. And these two side ports are on opposite sides of the microcatheter, much like with the Stingray, giving you access to the vessel from both sides. The other important thing about the device is it's oval, which reduces its profile for crossing. And this is important because in certain circumstances, if you wanted to use this device when you were 6 French, you can trap it using a dedicated trapping balloon. A couple other things to mention is the trackability of the device. So this is facilitated by one, the stylet through the blue lumen, and secondly, by a core wire within the device itself. And there's also a braiding around the blue channel. In bench testing, when it's the force transfer through the device was compared to the Stingray, you can see here that with the stylet in or with the stylet out, the device transfers force through to the tip that's greater than the Stingray. And certainly I've seen this borne out in the cases where I've used it in clinical practice, and I'll show you a case later that illustrates this. Okay, to the cases. So the first case, this is a 63-year-old man who had a bypass in South Africa 15 years ago. And we know that all his vein grafts have been occluded for 4 years. He's presented with refractory angina. He's got preserved LV, and the target is to do CTO PCI to his right coronary artery. So if we start with the video on the left, you can see he's got a complex post-bypass occlusion of his right coronary artery. The proximal cap appears to be quite close to the ostium or at the ostium. And we see distal filling to just in front of the bifurcation. So it looks like the distal cap's down near that bifurcation. There's ambiguity about the course, there's tortuosity, there's calcium. There's a septal collateral you can see coming over from the native LED. And we see this more clearly in the aerial view here. But what we see is that the S1 breaks into a series of very small collaterals that are not particularly attractive, but may well be crossable. So this is a high complexity CTO looking at the objective scores. So my feeling here was our highest likelihood for success was going to be to do RDR with a bailout strategy of ADR if that was unsuccessful. So we crossed the septal quite quickly with the Scion and a Sewell 3-wire and followed that with a microcatheter. But you can see at the base of the septals, we couldn't get the microcatheter to cross that last segment, even changing out for a lower profile microcatheter, and even after gently ballooning that area, we were unable to follow. So what I did was leave the microcatheter in the septal and track the wire forward and use it as a retrograde marker wire, which you'll see as the case goes on, it proves very valuable. Interestingly, with the microcatheter in the septal, if you look at the VT on the right, you can see that the antegrade filling actually improves. We're now seeing an ipsilateral collateral and bridging collaterals fill the vessel. And in fact, with that in the marker wire, we can see the occlusion shorter than we thought. It's still long, but it's a lot shorter than we thought. And the distal cap is proximal to the bifurcation. So I started working antegrade. This was difficult. We needed a CP12 to get across the proximal cap. Couldn't follow it with the microcatheter, but managed to wedge a small balloon in, inflated that, which got a bit of grip on the cap and was then able to knuckle forwards. We continued knuckle down through that ambiguous segment. You'll see in these two videos that this kind of clearly elucidates the tortuosity in that mid to distal segment of the vessel, which we could see earlier from that retrograde marker wire. So very quickly down to that distal right coronary. So we elected here to do classical ADR using the Stingray balloon. So we delivered that with a Miracle 12, used a Hornet 14, and punctured through and did stick and swap technique where you puncture with the Hornet 14, swap for, in this case, a Gladius wire, which we were able to deliver distally. So what I have to be very careful about here is that I think I've re-entered very close to the bifurcation. And the key thing here is if I've re-entered beyond the bifurcation and I stent, there's a good chance I'm going to push that subintimal tissue across the other major side branch and lose the other major side branch. So we performed IVAs. And my feeling with this IVAs was I could see my marker wire, but my feeling was that there was a tissue plane between the two big branches at the bifurcation, and I really wasn't keen to proceed to stenting. So I thought what I'll do is I'll take a dual lumen down and I'll see if I can try and access the other branch. So I took a dual lumen, so I did took a dual lumen down, couldn't access the other branch. So by this point in the procedure, we're 2.5, 3 hours in, patient has a lot of contrast and radiation. So I want to secure that bifurcation. So I decided that what I'm going to do is perform dilatation and stage completion of the case. Oh. Sorry about that. Stop sharing. Sorry, I just closed my presentation. Give me a second.
No worries. While we wait for it to come back, I think that many people would have just sort of at the initial point said, let's salvage one of the branches and be done, because we've had a success in a very, very difficult CTO. But I think the challenge here for this patient is you want to try to get the patient as much revascularization as you can. And then I think what I anticipate is you're going to show us the use of the dual lumen to get both branches.
Exactly. So leave the patient for 6 weeks, bring them back, and I decide I'm going to go with single access just to see what I've got first of all. So interestingly, the whole filling of the vessel is completely changed. So now we can see clearly that there's a good vessel right back to the mid segment where that marginal branch comes off. And interestingly, we can't see angiographically that track that I created all the way around that bend. So quite interesting. We see obviously these bridges and ipsilateral collaterals better. So I know that I've created a plane down there, although I can't see it. So I decided what I would do is that I would take the ReCross and see if I could use the ReCross to find my way and reduce the segment of subintimal track that we would treat. So this time my plan is to integrate device-based re-entry and use RDR again, potentially as a bailout, although accepting the fact I've had trouble with the septals the last time. So I took a regular McEntegart to start with, and I've just a silent wire. You can see immediately it goes into that extra plaque plane that I've created the last time. I switched for a Gladius wire, a jacketed wire, and tracked down to just beyond the distal cap. So this is the scenario that I'm in here. So I'm in the extra plaque subintimal plane beyond the distal cap, and I'm going to try and use the ReCross now to re-enter. So that's a ReCross in place now. So I take a Gaia third wire, and this is out the blue port, so 8 millimeters back from the tip. And initially I'm thinking that looks pretty nice. I think I've re-entered, but as you should always do, I come round to the contralateral view, and you can see in the aerial that I'm still extra plaque. So what I did here is what I do routinely now with this device, which is called a straw and stick technique, which is where on one port you put a syringe and you put negative pressure on it, basically to compress any hematoma and try and compress the subintimal space to make it tighter against the device to improve my ability to contact the tissue and puncture through. So I did that, and I took a CP12 now out the white port, and you'll see that this punctures on the first attempt through into the true lumen.
Margaret, did you pull the white port wire out before you went through the blue port, or you left it in?
So sometimes it depends. Sometimes I leave the wire in, and sometimes I take the wire out and I do the aspiration technique and puncture out the other port. Just depends on each individual case. If you leave the wire in, sometimes it improves your support. So it's a balance between wanting support and wanting to decompress the space.
But modifiable and titratable. Pretty cool.
Yeah. So you can see really nicely here, the ReCross device sitting extra plaque and the wire now in the lumen in both views. Okay, so we ballooned that up and went on to perform IVUS. And this just, you can see hematoma, probably some residual from the first procedure and some disruption. And I'll try and speed this up a little bit, but you'll see we're then clearly extra plaque here. And then that's all extra plaque with that classical crescent shape you often see when you're extra plaque. And then we come back into the lumen here. Okay, so we go on and stent that. And then interestingly, if you look downstream, you can see there's a kind of funny appearance down where the bifurcation should be. So I IVUSed that to see if I could identify the access of the other side branch, took the ReCross down and used it as a dual lumen here and was able to puncture through and get access to the other vessel and then stent across that area. And then we end up with a nice result. So I think really nice, elegant use of the device to try and keep your space small, decompress any hematoma you've got and perform re-entry. So the second case I've got is kind of, I suppose, at the slightly other end of the spectrum. This is a 75-year-old man who presented through the course of last year, through the pandemic, with multiple end STEMIs. And in between times, he's been suffering with daily angina. He's also had a bypass before, 15 years ago. He had a lima to his LED, he had a vein graft onto his OM with a jump to OM2 and a vein graft onto his right. Came in December with global ischemia on his ECG to one of the local PCI centres. They found his lima was occluded. The vein graft to his right was patent. And there was a very calcific subtotal occlusion of the vein graft to the OMs. I'll show you in a second with slow flow. So the area of ischemia is the circ OM territory, but also he's got now an ungrafted LED territory as well. He's got a CTO of the ostium, his left main, and a CTO of his right. So very complex disease. So here's his angiogram at the base hospital. So he's got a vein graft onto his right that's working, and you can see it's filling both the OM and also the LED. So very, very important graft. Very long course around that retrograde to the left system. And then this was the vein graft. It's this horrible calcific lesion in the vein graft. Now, at the base hospital, he had 2 attempts to try and wire this. One of the guys who tried to do it is a CTO operator using all the usual kind of integrated CTO wires and McEntegart, but just couldn't cross this lesion at all. And actually, every time he touched it, the guy became incredibly ischemic and hemodynamically compromised. So he managed to settle him, and it was right in the middle of the second wave. So he let him go home with a plan to send him on to us a week or 2 later as an outpatient. But he actually got readmitted. We transferred him as an inpatient, unstable. So my analysis of this case is that he's having resting ischemia in that circumflex OM territory. My strategy when I saw the previous angiogram was I'll see if I can get through that graft and get down and do RDR back out of the circumflex in the left main. But if that doesn't work, then the other option is to try and do ADR down to OM1 and OM2 and use the jump graft between the 2 OMs to secure both vessels. I want to maintain access to his LED because he's lost his graft to his LED. So quite complex kind of strategy thinking about this case. In fact, when he came to us, of course, the vein graft had completely gone. So all we're left with is this vein graft to the right, which is supplying everything, high jeopardy, long course, and I'm not keen to use that. I've had VF in cases before when we've tried to do that, and I'm always reluctant to do it without certainly significant hemodynamic support. And this is the left main. So my RDR strategy via the vein graft to the OM is gone. I don't want to go retrograde via the vein graft to the right unless I absolutely have to. So my strategy now is to do ADR down into OM1 or OM2 and try use a jump to get into the other branch. But I want to preserve access to the LED. So I've told the guy that he's going to need at least 2, maybe 3 procedures for us to secure his hit of the whole left system. So the first procedure took quite a long time, Hornet 14 with a turnpike spiral to eventually get purchase on the left main, managed to get into the proximal circumflex, and with a lot of work and lots of ballooning with small balloons, eventually managed to knuckle down to the bifurcation. It was very difficult. Having modified that, I then used the Hornet and the McEntegart to get into the LED, again knuckled down and ballooned all that up as well. So this all took about 2.5 hours, so we stopped. I let him go home for a week. I brought him back, and this is the picture you see on the left. So we've created good investment modification of the left system. And then I was very quickly, within 5 or 10 minutes, able to get a knuckle down into that first OM with a microcatheter, having taken me about 90 minutes the procedure before. So with some difficulty and with lots of ballooning, I got the stingray down into that OM1, and I'm trying to re-enter. But the important thing here is I'm in front of that jump that supplies OM2. So I've got a very short window to try and re-enter. So I've fenestrated multiple times, you see in that picture on the left, but was never convinced that I was in, and I couldn't really visualize what was going on downstream. So what I decided to do was leave a wire in that space, and I came back and re-knuckled down into OM2, and you see that knuckle go down into OM2. So having had great difficulty getting the stingray into OM1, I decided to take the ReCross. So I took the ReCross down that knuckled space, and on first pass managed with the guy a third to stick straight into OM2 out of the stingray. Out of the ReCross. And you can see here the jump filling nicely back up towards OM1. So then what I did was switch out for a wire, use the ReCross to wire up at the jump graft. You see on the right hand side, that's the second wire going up the jump. And then exchanged out for a single Lumen microcatheter, followed that wire around. And you'll see I'm able to wire back up through the circumflex retrogradely. So I've got a wire in OM2, I've gone round the jump and back out through OM1. And what I did here was I did a RDR in the proximal circumflex. So because I've got a single guide, what I did was tip in. So I connected in the proximal circ, wired into the guide, and then I brought an anti-guide microcatheter into the guide and wired into that microcatheter. I then chased that microcatheter forward, back in the retrograde microcatheter back, very careful not to let the two microcatheters touch. So ultimately I end up with a wire anti-guidely in the OM1, a wire anti-guidely in OM2. So on the left you can see me pushing the anti-guide microcatheter forward and very carefully backing the retrograde microcatheter back. And then you can see on the right hand side the two anti-guide microcatheters now. You see that one backing up through the circumflex. So I balloon both limbs of the vessel, balloon right back out the left main with high caliber non-compliant balloons. And you can see already that the retrograde filling of that system's decreased because I'm now getting anti-guide filling with what I've done. And I stopped. So this chap's due to come back in the next couple of weeks, and what I'm going to do, he's been completely stable now for 4 weeks at home. And what I'm going to do now is I'm going to open his LED, and then I'm going to reconstruct the whole left system. I've recanalized all 3 branches. So I think it nicely illustrates that case, the ability to use the ReCross even when you've knuckled to re-enter. So I'm just going to finish briefly by showing you what I think about how I use it in my practice. So in the situation where I've tried to wire the vessel and I'm within the occlusion, but I'm not sure I'm in the right place, I'll sometimes use ReCross for wire redirection or the parallel wire technique, depending on the situation. If I've tracked beyond the distal cap, extra plaque, but I haven't knuckled, I feel in my practice so far a really nice success rate by tracking the ReCross like you saw in the first case and using it to controlled re-enter beyond the distal cap. If I've knuckled, I still conventionally will use a stingray. But in situations like that last case where I anticipate having problems with the stingray, I've had good success with using ReCross to re-enter in a traditional kind of ADR type technique. Thank you.
Margaret, that was fantastic. I think first the cases are high level complexity cases and illustrate the use of a variety of techniques. But the way you've actually illustrated the use of this specific catheter, the ReCross, in the algorithm is pretty interesting, because I think for a lot of operators, when that first wire sort of goes offline or goes extra plaque, the options that at least have been traditionally taught at many conferences have been immediately go retrograde, immediately knuckle, and then you're dealing with hematoma management, large planes, and that sort of thing. And there's been a small group of people who sort of said, well, try parallel wire or try redirection, but that's not the easiest thing to do. And you're dealing with multiple catheter systems. By the use of a catheter that can also be used for dual lumen purposes and open vessels or otherwise is pretty interesting. So I think that it almost seems to me that this affords sort of an intermediate step before having to take out the big guns and make big hematomas and just end up with investment procedures. Is that an accurate summary of what you've been doing?
Yeah, I would say so, and I think that it's going to be really interesting to hear Gabriele, because I think the traditional idea of there being kind of two worlds, I suppose, like the conference is set up, I think this device is kind of starting to bring them to bridging that, I think, a little bit. And I think for me, what it's done in my practice has made me much more flexible and open-minded about what I do in the cases, and I really tailor what I'm doing in each individual case rather than being very, I've done this and therefore I have to now do this. So I think you're right. I think it's kind of maybe about fine-tuning and refining our thinking around the algorithms, I think.
Gabriela, what are your thoughts on these cases?
Yeah, I have a question. So first of all, congratulations, Margaret, for your excellent cases that you show us. But I have a question for you. You have a great experience with the Stingray system, of course, but I would like to know if ReCross microcatheter could change your practice, not in terms of approach, not in terms of strategy, but in terms of first choice microcatheter in case of antegrade approach.
Yeah, it's a really good question, Gabriele, and I've been wrestling with this myself actually, because I suppose it's like everything else. You kind of have ways you do things, and often you're comfortable approaching a proximal cap with a mic catheter you use all the time, and maybe crossing the proximal cap with a mic catheter. So I am exploring that at the moment. Taking it up front as my first mic catheter in some cases, but in some cases, like the big calcified post bypass cases, I'm still inclined to take my usual antegrade type workhorse mic catheter and then using it later in the case downstream. But I know that both yourself and some of the other European operators that I've watched present on this are using the device much more upfront as their first mic catheter. So that's something I need to further explore in my practice.
And usually, if I understand well, your first choice microcatheter is Corsair Pro, isn't it?
Yeah, so we basically, some of our, I don't know whether with you, but some of our decisions are based on procurement with cost and finance. So we have a huge procurement package with Corsair and Caravelle, and then we have a small package with Spirals and the other, different microcatheters and ReCross as well. So it's about, with us, it's volume. So I'm kind of pressurized locally into using high volumes of the same microcatheter, and I'm only allowed to have small volumes of some of the other mic catheters. So that to some degree dictates what I do.
One basic thing for that here in the US, we get to see what you all are doing, and then we have to wait to use it. In terms of crossability, not only the charts you've shown, but also the prior webinars have demonstrated that it actually crosses very well.
It does.
But, in terms of the technique, though, this is tracking over a wire, or can you do gentle spinning but not aggressive spinning? How do you take it down the vessel?
Most of
Margaret,
Are you spinning it, or are you gently advancing?
Yeah, for me, most of the time I'm sliding it. And I'm sliding it usually initially with the stylet, and then if I get to a particularly tortuous segment of the vessel and I'm finding I'm not progressing as quickly as I like, I take the stylet out, and that works quite nicely, especially like for instance in that second case, I got halfway down with stylet in, took the stylet out, and then was able to slide it on. I haven't been doing much spinning or torquing with it. I don't know whether Gabrielle has much experience in using it.
I think that ReCross is not really a spinnable microcatheter. I mean, but you can apply a gentle torque when you advance it. So it could be useful to push with the left hand and to apply a gentle rotation with the right one, but no a spinnable microcatheter.
It's oval shape.
Yeah, it's pretty interesting though, because you have so many options. You can take it with the stylet, you can take it without the stylet, you can do straw through it, and there are a lot of permutations for use. And Margaret, your first case showed that, where you basically used it first to sort of do a modified ADR without a knuckle, and then second to recover the side branch. So with trapping and the ability to do it through 6 French, it affords you the ability to take it out, put it on the other wire, and do a variety of techniques.
It's also useful because in the occasional case, let's say a colleague has accidentally gone subintimal in a regular PCI. So the ability to take it down the 6 French in that situation and bail them out by re-entering or doing parallel wire or whatever is very helpful.
And then do you find specifically that one port or the other is easier to maneuver through or to wire through because one's braided and one's not? Or is it just depending upon the directionality of where you are?
From my experience on the directionality and where the device is sitting in relation to what the vessel lumen looks like, so I've successfully, I think, re-entered through both ports probably equally. I think anecdotally, I haven't looked at that specifically. I don't know, Gabriele, what do you think?
I think that if you have to redirect the micro, you can. It's not so easy to redirect the micro once the micro is inside. So if you are not satisfied from the position of the 2 different exit ports, you have just to withdraw a little bit for a few millimeters the micro catheter and then re-advance it with gentle rotation in order to change the position of the exit port.
Yeah, the 2 exit ports are separated by 4 millimeters and on opposite sides. So it gives you a little bit of flexibility in terms of location of where you are. Well, that's great. I think we'll move on to Gabriele's presentation now. I'm sure there are going to be themes that are going to be similar, but some specific tips and tricks, and keep the questions as coming through the chat as well, and we'll bring those up, because otherwise you're just going to hear my naive US-based questions because we don't even have access to the catheter.
Okay, so thank you, AJ, and thank you, IMDS, for this great opportunity to discuss once again the versatility of ReCross in complex PCI, such as CTO PCI. So the first question that we have to discuss, but it was already discussed during 2 previous seminar of this series, is should ADR and true be considered 2 different words? But there was a general consensus that both of these techniques are in the same word, that is the word of CTO crossing techniques. So the question is it's not really a matter. But the second question, and we also have seen the experience from Margaret regarding how and can the ReCross microcatheter fit into existing algorithm. And here I reported the most adopted algorithm in Europe, the EuroCTO algorithm, and the hybrid algorithm as well. And during my presentation, I would like to show how ReCross can fit in my personal algorithm. So this is my personal experience during last 3 years since the ReCross microcatheter was available. And I think that we can appreciate that the ReCross microcatheter has not changed my strategy, my strategy in terms of approach. I mean, the rate of antegrade approach remained the same, and also the rate of ADR strategy. I'm not really a fan of ADR as a first intention strategy, but I think that it should be useful, and it should be well known in the armamentarium of each CTO operators. But interestingly, I appreciated that the ReCross changed my strategy in terms of choice of first antegrade microcatheters. So this is the rate of utilization of the ReCross microcatheter during the last 3 years in my personal experience. And now I'm using more frequently, or I decided to use more frequently, the ReCross microcatheter as a first choice for antegrade approach. And I'll show you my early experience, because I collected less than 20 cases because the ReCross microcatheter was available in my cath lab since last year. So this is to simplify the EuroCTO algorithm. I skipped the retrograde steps, and these are reported only the antegrade step of the EuroCTO algorithm. And the ideal situation, as underlined by Margaret in her presentation, is the situation with a clear proximal cap, no bifurcation at the distal cap, so we can start with an antegrade wire escalation without any doubt. And this is a case that I performed in July of 2019, when I had the opportunity to test the ReCross for the first time. And I was treating CTO of the third with a clear proximal cap, as you can see from the video. And the only anatomical aspect that we have to consider was the length, more than 20, and no calcification, no bending inside. And another interesting aspect could be this bifurcation with this small side branch that sometimes could deviate your guide wire into a subintimal space. So I decided to use it because I should also have to test the ReCross, and I think that it was a good case. And I start with an ultimate Bros 3Y, because in this case I decided to skip the Fielder XT because of the lack of micro channel. And this is the real-time advancement and puncture of the proximal cap with the ultimate Bros 3Y. As you can see from the video, the right puncture and the drilling technique. This is I love this wire because of its excellent tactile feedback. And this is the real-time crossing of the CTO body and reaching hopefully the distal through lumen. So this is the first angle to check the right position, and the second orthogonal view to the confirmation of the right position. And then I advanced the microcatheter, the ReCross microcatheter, and you can appreciate from the video from the cath lab the technique to advance. It's not really different from the technique to advance the Corsair microcatheter, but with the attention not to spin too much this microcatheter. So with the left hand you have to push, and with the right hand to apply gentle torque in order to facilitate advancement. And I think that this case was a good test because of the length, and also because the circuit is not so the easiest coronary to reopen or to cross, but the advancement of the ReCross was quite easy and quick, and finally we achieve an excellent final result. So this is an example to show how, in my personal algorithm, the ReCross microcatheter fit well in cases where I have to use as a single lumen microcatheter when I plan to perform an antegrade wire escalation. And the second situation is the opposite one, when there is some proximal cap ambiguity, so no clear proximal cap, or where there is a clear proximal cap, but bifurcation at the distal cap. So in this case, the most problem is not to lose one of the two side branch, because the aim of the CTO PCIs is to offer to the patient the most complete vascularization as possible. So this is what not real a very complex CTO, but the distal cap was at the level of the crack. So also in this case, the antegrade wire can be deviated by the shape of the distal cap into a subintimal space, or you carry the risk to lose one of the side branch, such as PDA, for example. So I advanced it without any problem, the ReCross microcatheter as a single lumen microcatheter, and finally Gaia second, that was my first choice guide wire in that case, was able to reach the distal true lumen of this posterolateral branch. So this is an ideal situation to use a dual lumen microcatheter. And in this case, the versatility of the ReCross was very helpful, because I had just to advance just a little bit more the ReCross at the level of the bifurcation, and then advancing a second guide wire that was able to reach also the PDA. And after that, I changed the wire, I removed the microcatheter, and I performed PCI with this final result, with preservation of both of branches. So also in this case, I mean, that not all bifurcation at the distal cap are the same, but this microcatheter could fit very well even in case of bifurcation at the distal cap. And I remember that during the previous webinar of this series, also Dr. Elliot Smith discussed about the utility or to consider the ReCross microcatheter, even in this case of bifurcation of the distal cap, even when you perform an ADR strategy. And the other opportunity that can occur is when we started to plan with an antegrade wire escalation, but the first wire went subintimal, so we need to perform a parallel wire technique. And this is an example of a second attempt of a previous CTO that was performed in another hospital. And during their attempt, they create a large dissection, antegrade dissection, and also they tried to go retrogradely, but finally they were not able to select the right collateral, the right septal. So after that, they decided to stop the procedure, and then the patient came to my attention, and I plan to perform derecanalization starting with an antegrade approach because clear proximal cap. Also, the length was not so, was no more than 20, so it was really not a complex PCI, but the only concern was related to the previous dissection plane that they created during their procedure. So I decided to start with the ReCross microcatheter because the likelihood that my wire goes subintimal was quite high. So this is what happened. The first wire that I decided to use was a Gaia second, and the Gaia second went subintimal, maybe in the same dissection plane of the previous procedure. So I decided to perform without trying to redirect the first wire in order to avoid enlargement of the dissection plane. I decided to perform directly a parallel wire advancing from the blue port, stiffer wire. In this case was a Gaia third, and this is the real-time crossing from the true proximal lumen to the distal true lumen that was confirmed by retrograde angio. And at this point, it was quite easy to advance the ReCross microcatheter. This is a real-time, so you can appreciate how smooth and how simple is progression of the ReCross in such kind of lesion. And interestingly, I appreciated that once you become more confident with this device, obviously all of us, we are have an early experience with this relatively new device. I decided to switch the wire with a workhorse wire advancing directly through the blue port workhorse guide wire. So this was very quick maneuver. And once the workhorse guide wires was into the distal PDA, I removed the Gaia second and the ReCross at the same time, and achieving this final result without preserving also the bifurcation. So also this case show that in case of need to perform the parallel wire, of course, the ReCross, it's a very useful microcatheter, such as all the dual lumen microcatheter when you have to perform the parallel wire. But the most important benefit that you can perform directly if you advance or if you start with the ReCross microcatheter, you can perform immediately the parallel wire without the need to change the single lumen microcatheter with a dual lumen one. And I have another interesting case in which I had a different situation with the proximal cap ambiguity. So this is the situation in which we have some strategy to overcome the proximal cap ambiguity, such as base technique, scratch and go, or IVUS guided puncture. And I would like to show these cases. And as you can appreciate, there is no clear proximal cap. and I advance a worker's guide wire until this side branch close to the bifurcation at the level of the proximal cap. And once I reached the occlusion, I decided to switch to change to advance a second worker's guide wire through the blue hub in order to have the opportunity. So this wire is not the previous one, but is a second one that I advanced from the blue lumen into the side branch in order to have the tip part free to advance another CTO wire to puncture the cap. And this is exactly what I did. I decided this is maybe a case, also a good case for IVUS guided puncture. But in this case, I decided to perform the scratch and go technique. I punctured the cap with the Gaia third wire. And once I punctured the cap, I advanced just for 2 millimeters, no more, the ReCross into the plaque, into the proximal cap. And I obviously have to be sure that the microcatheter is into the vessel structure. And when the microcatheter move in concert with the vessel, it's a good sign that the microcatheter is in the vessel structure, in the architecture of the vessel. And after that, I can advance polymeric guide wire. This was a Fielder XT wire that I advanced in a knuckle fashion. And as you can appreciate from this angio, I had also a spontaneous re-enter of the wire because the knuckle here closed, okay, when the wire re-enters spontaneously in this side branch. So this was a good position of my antigrade knuckle wire with a spontaneous re-enter in this side branch, very close to the bifurcation. So at this point, I advanced the ReCross microcatheter over the polymeric guide wire close to the bifurcation, and then from the blue port, I advanced a second CTO wire. This was a Gaia second wire that was able to gain the true lumen of the main vessel, I mean, of the PDA. And after that, I changed the wire. I checked for the right position. I changed the wire using the ReCross microcatheter, and I performed the PCI, achieving a good final result in order also to save this side branch. This is a further confirmation that the re-enter of the knuckle wire was before the cracks, before the bifurcation, sorry. So also in the case of proximal cap ambiguity, the ReCross could be very useful to perform several techniques in order to overcome the ambiguity, such as scratch and go. And until now, I don't have any experience in using of ReCross microcatheter performing the IVUS guided puncture, but I think that could be can fit also in this kind of technique in case of IVUS guided puncture. And finally, this is the last cases in which I started with an anti-grade wire escalation that was ineffective. I tried a parallel wire that was ineffective, and I finished the procedure with a bailout ADR. This is the case that I performed with my friend Jacopo Aurelia during last CTO Live Aid. So we started with an anti-grade wire escalation, but the wires went subintimal, so we switched for a parallel wire, but also the parallel wire was ineffective, so we decided to push, to advance a little bit more the ReCross behind the occlusion in order to perform an integrated dissection re-entry strategy. But obviously, due to the reiteration of the manipulation of the wire, maybe we create a large hematoma, so we were not able to achieve a re-enter of also the Ornate 14 that we try to gain a re-enter wire strategy. So we decided to inflate a balloon into the mid part of the RCA in order to stop the filling of the hematoma, and using the blue part, we did a straw technique to reduce the hematoma, and finally the Hornet 14 was effective and punctured the intima, the subintimal space through the distal through lumen. That was confirmed by this contralateral injection. And after that, we changed the wire with a standard wire, and we went on with revascularization. So even in case such as this case and such as the case that show Margaret, in case of ADR, this is a very useful device that can be used. So the key learning point of my personal experience is that the ReCross, it's extremely versatile microcatheter. I think that this is the most important aspect of this microcatheter, its versatility, and it can fit perfectly into the existing algorithm without altering it. So we can use it as a first choice antegrade microcatheter, independent of the CTO crossing strategy. And the last key learning point is the same of the key point that was discussed during our previous webinar of this series and from Andrew Lucking. This microcatheter has also a potential role for operators expanding their skill set from antegrade wire escalation to ADR. So even for operators that are starting their CTO experience, this microcatheter should be used, because could be also useful when you have to learn for the first time the antegrade dissection and re-entry strategy. So thank you very much.
That's a great series of cases and very complimentary as well. I think that, you know, one of the questions that we were sort of thinking about as seeing both of your presentations, but also in reference to the prior webinars, is that on that spectrum of complexity and tools and that sort of thing, do you get the sense that, you know, for a variety of reasons, whether it's due to complications, experience, and otherwise, that even for experienced operators, this can result in a shift away from potential retrograde and more to antegrade as a successful strategy up front? Not to say that you shouldn't learn retrograde. We all know you have to. But I think that some of the cases you illustrated where in the past you might just sort of default and have to go a different direction. Some of the cases you didn't have that option, but yet you were successful. So I'm just wondering if folks are finding that you perhaps may succeed more often antegrade than in the past. Maybe Gabriella first and then Margaret.
Okay, so as I show in my first slide, actually ReCross has not changed my strategy in terms of approach, but I have an early experience with this device because it's relatively new, and operators should become confident during time with this, not with this device that is very easy to use, but in different subset where you can use it. So in my experience, I don't know if the ReCross can change the rate of antegrade approach compared to the retrograde, but it can change the mindset in terms of choice of first choice antegrade microcatheter. Yeah.
Margaret, what do you think?
I don't know, Margaret, what's your opinion about that?
I think it probably does have the potential to slightly change it, because I think that for people who maybe previously haven't been schooled in using the parallel wire technique, it's maybe inclined to make them use that more than they may have done before, even if at all. And I think also, that in situations where we all know that the Stingray is a fantastic piece of equipment, but there are undoubtedly situations where you can't use it, or you've used it, you've failed, you've come out, and then you can't retrack it. So I think that there's over the last number of years, with an evolution of a lot of the antegrade technology, I think antegrade success is going up, and I think ReCross will be one of the tools in that in that progression, I think, towards us being able to do more cases antegrade, I think. So, and I think it is interesting, the thing that Andy Luckin mentioned the last time and that Gabriele just mentioned there, this idea of maybe it being an easier device to transition people from antegrade wiring to ADR. It's certainly, if you can use a dual lumen microcatheter, you can use this. So I suppose it's as people train, it's incrementally quite an easy thing to teach people to adapt into their practice. So I think it maybe does give us an incremental shift in that direction.
Yeah, I think that the one case that where you showed with the hematoma management, that issue of once you have a hematoma, typically with Stingray, it's tough to get out of that situation, and many of those patients end up with stars. So even if it doesn't work every time, the ability to get out of that situation by the proximal balloon as well as the distal aspiration, and then to re-enter, that's a big save, because otherwise that patient's coming back for another procedure. And I thought the case before that was sort of the it's like the step-by-step ladder approach, where you have one branch, then you find the main lumen, then you find the other branch with the dual lumen catheter. That was very, very interesting. One question about that case for you is that you used it as sort of a scratch and grow through the distal lumen. I think intuitively many people would think maybe you should do the scratch because of the orientation that you decided to do it through the distal lumen, or was there another reason for that?
AJ, sorry?
Yeah.
There was some lack of audio.
Oh, sorry. No, I was just asking for the scratch and go. Oftentimes, the initial direction you want to be off at an angle, whereas in this particular case, you use the scratch and go through the distal lumen, which was innovative because then it allowed you to advance the catheter down. Do you find that you're doing it that way more often, or are you sometimes doing it through the side?
No, okay. So you mean the last case that I show? Okay, we try to puncture with Ornet 14. So we had no problem. I mean, once we aspirate the hematoma and we block the antegrade filling with the balloon, it was very, very simple and easy to puncture the subintimal space into the true lumen with the Ornet 14. At this time, we were quite sure to be in the true lumen, and we advanced the Ornet 14 directly, distally. And once we advanced the Ornet 14 distally, we advanced the ReCross and we changed with the standard wire without any problem.
I think the other reason, Ajay, that was a nice approach with Gabriele in that case with the mid-right, is that the first exit port is 8 millimeters back from the tip. So if you're actually at the cap and you can't get so using this is another nice thing about the device. Just like Gabriele illustrated, you can actually use the tip to do your puncture or scratch while supporting it with a wire out of the other side branch. So it's a nice innovative way to use it, because you might perceive the fact that your side port's 8 millimeters back as being a limitation, but actually if you can almost reverse the usage in your mind, allows you to get around that.
No, I think that's right. And then also the advantage of using that distal port is then you can just use the microcatheter to advance, as opposed to having to trap it out and then bring it back in. So pretty interesting as a whole.
Yeah, very nice.
Well, I think we're going to certainly hear more about the use of this either upfront or for specific cases. I thought that, Gabriele, your point about for specific cases where you think the wire is likely going to go subintimal, to then you use this as a way of then getting back in a parallel wire type approach or other redirection type of approach is pretty interesting. And I certainly look forward to seeing all of you put these experiences together, because it's kind of like the early people said, well, this you need to use for every case, but then what ended up happening over time is that it's used for specific cases, but not every case. So the range of cases that this can be used in and how it facilitates getting through the case, moving faster, is going to be pretty important for all of us certainly to see. Any other thoughts or comments? I think this is a great webinar as a whole. I certainly learned a ton just seeing the cases as in addition to the first two webinars, which also offer a great complement of different uses of this device. Any words to wrap up, Margaret?
One other thing I kind of thought of recently, and when I was reviewing the cases for the webinar, was seeing the stage completion cases, you know, so the really complex kind of JCTO4 or 5 cases where you've had to do a lot of, maybe done a complex RDR and you haven't secured your side branches and you're coming back to complete. So you've ballooned everything up the first time. I think it's very useful in that situation. Because as Gabriele was saying, there's good likelihood you maybe go into a subintimal plane, you can parallel wire, you can use it to secure all your side branches. So I think as a stage completion CTO microcatheter, it's very useful.
And that's fantastic. Gabriele, any final thoughts?
I just to underline once again that the main technical features or the main innovative aspect of this micro is its versatility. I mean, you can start with a single lumen microcatheter, and then in case of need, you can switch to a dual lumen use of this microcatheter, and also for ADR device. So it's also important for another aspect in terms of cost effectiveness. So you can use just one device and you can perform several different techniques, and without using 2 or 3 different devices in the same procedure to perform a parallel wire or to perform a distal reenter. So I think that the versatility of this device is the key point of this microcatheter.
Well, fantastic. I think that's a great way to end. And so to all the audience, both on live now, as well as we'll be watching on demand, thanks so much for joining us. This was a very, very interesting, 2 great speakers, 2 great operators, and a lot of patients who've been helped. So thanks again, and look forward to seeing you at the next one.
You're welcome.
Thanks, Ajay. Thanks, Gabriele.
Thanks, Ajay. Thanks, Margaret. And thanks, IMDS, of course.
Yeah. Thank you.